Well, thank you everyone for joining us today. Today we will be presenting a webinar as a part of the Iowa Cancer Consortium's capacity building series entitled Preventing Lung Cancer, Radon Education and Healthcare Providers. My name is Allie Bain and I'm an outreach specialist here at the Iowa Cancer Consortium. The ICC was formed in 2001 and is a nonprofit membership organization that works to improve disease prevention, early detection, research, survivorship, and quality of life for Iowans affected by cancer. This webinar is one of a series meant to increase cancer knowledge among the ICC members and partners. Today's webinar is being recorded and will be available on our website at www.canceroiowa.org. At the conclusion of today's webinar, there will be an evaluation sent to you. The survey will automatically open in your browser. Please take a minute to fill out this evaluation to help us plan future events. Before we get started, let's walk through some of the features of the webinar. On the right side of your screen, you will see a chat box where you can interact with others on the webinar. Please indicate so via the chat tool, and we will work with you to resolve the issue. In response to January's Radon Action Month, we are privileged to have Dr. Bill Field from the University of Iowa College of Public Health and Dr. Barcey Levy from the University of Iowa Carver College of Medicine with us here today. As I introduce our presenters, please take a moment to introduce yourself using the chat tool. Dr. Field is a professor at the University of Iowa's College of Public Health with appointments in the Department of Occupational and Environmental Health in the Department of Epidemiology. He was the lead author of the comprehensive Iowa Radon Lung Cancer Epidemiologic Study and was one of the investigators who performed the North American Radon Epidemiological Pooling Study. Dr. Field serves as a member of the U.S. EPA's Science Advisory Board and chaired the board's Radiation Advisory Committee in 2014. He also served on the U.S. Science Representative to the World Health Organization's International Radon Project and as one of the 3 final reviewers for the CDC's She has a long-standing interest in cancer control research, particularly colorectal cancer screening and risk reduction for cardiovascular disease. She is the director of the Iowa Research Network, a network of family physician practices across the state of Iowa. IRENE includes about 310 physicians in 188 offices in 75 of Iowa's 99 counties. The mission of IRENE is to create new knowledge and improve clinical practice, especially in rural areas. Dr. Levy began working at the University of Iowa as a resident in 1990. She joined the faculty in 1993. Her outside interests include biking, swimming, reading, and spending time with family. All right, Dr. Field, the floor is all yours.
All right. Thank you, Ollie. And I'd like to thank the consortium for hosting this. I think that it's an important event and a great vehicle to get information out to different practitioners and healthcare providers, as well as those that work in health departments and serve other important functions to get the word out about radon. My voice may sound a little bit deeper than normal. I'm fighting a cold, but if you can hang in there, I'll see if I can get through this without developing laryngitis. So I'll move to the first slide. So as you can see here, the overview of 101% really reflects back on the learning objectives. I want to talk about radon occurrence, radon health effects, radon epidemiology, and patient education. And the first 3 learning objectives I'll be addressing then. Radon's a gas that's formed from the breakdown of uranium, then it decays to radium, then it becomes mobile as a gas and makes its way in the home. And what's really important is that we used to say that radon's naturally occurring, and we've sort of changed that a bit. It's naturally occurring outdoors, but the way we build homes traps it, so it's really enhanced indoors. It's not naturally occurring at the levels that we find in homes. We can build homes that are radon resistant, but a lot of places we just choose not to do so. As you can see, the excuse me, the radon potential varies between the states, but what's important is these red areas, which are the zone 1 areas. These are the areas with very high radon concentrations. You can even have high concentrations in low zone 3 areas. So the only really way to know if you have a radon problem is to test. And a lot of times I don't like to present this map because a lot of people use the map as where not to test. So they'll look at maybe a county, or they'll look at a state and they'll say, well, you know, we have low concentrations. I don't think we need to test there, but really all homes should be tested. This just gives you sort of a relative idea of the different radon measurement units. The EPA action level is about 4 picocuries per liter. WHO guidance is 2.7. Used pretty much everywhere else in the world except the United States is 1 picocurie equals 37 becquerels per cubic meter. And then over on the right side is sort of what the unit they use for all the minor studies. So this is a unit of cumulative radon decay product exposure, and you can sort of see the crosswalk there. So if you have 4 picocuries for 25 years, you get about 16 working level months. So how's radon enter a home? Well, in most locations in the United States, it enters from the foundation, so around the substructure of the home. It makes its way in through penetrations, through sump pumps, through cracks. So we generally think about 90% of the radon in homes is from really the subsurface around the basement of the home. And then in certain states, there can be high concentrations of radon in the water, and these water supplies are mostly private wells or groundwater supplies. If you get a water supply from the river, there's going to be very little, if any, radon in that, but it's mostly from private well water supplies. So the real risk is not so much from drinking the water, it's when it becomes airborne in the home and you breathe it. And what a lot of people don't realize, it's not really the radon gas that causes the lung cancer. It's really these little radon decay products that are solid particles that are produced by the radon gas. And as radon enters a home, it goes into the home and decays in these little solid particles that, if inhaled, release alpha particles. And 2 of the decay products, polonium-218 and 214, which decay by alpha decay, deliver the majority of the dose to the lungs. So these are the ones responsible. So you breathe these in, and even the surface of your lungs living, if these alpha particles, if these decay products land on your skin, because they don't go that far, they don't cause much damage. They really don't penetrate into the living layer of your skin. But when you breathe them in, they get embedded in your lung tissue. Even the surface of your lung, obviously, is living tissue. So that what they do is very often can cause double-strand DNA breaks, which is somewhat unique for alpha particles compared to other environmental carcinogens. The other thing they can do is, as they hit your DNA, is they can cause free radical formation, which can also cause double-strand, more likely single-strand DNA breaks. And studies that we performed a few years ago at Iowa just shows one gene in particular, GSTM1. If this is a gene that you don't have, and half the people listening to the webinar today do not have this gene, then you're at 3-fold increased risk of developing radon-induced lung cancer. And it's because what this gene does is it produces antioxidants to help fight off the free radical formation from the radon. Just the same, if you have a defect in your tumor suppressor gene, you can also have a higher risk of developing radon-induced lung cancer. Just to show you how powerful or how strong, how much of an energy these alpha particles deposit is, this is a piece of plastic from what's used generally to measure radon in a home. This is from a long-term test. And as these alpha particles go in the detector, they can deposit when they hit the plastic, they can hit the plastic and creating little holes. So you can imagine if these alpha particles can leave a trace on plastic, obviously what it can do to your DNA. performed globally, all over the world, back from the 60s, and they're still being performed. These cohorts are still being updated. So what they do is they'll measure the radon in the various mines, and then they'll follow these individual workers over time. And what we found from the radon-exposed miner studies is that their concentrations, their exposures are very high. And I'm not sure what happened to the working level once put down there, but anyway, you can see sort of the distribution of what they were exposed to. So a lot of them were exposed in the range that we find people in homes exposed to, 20 picocuries per liter. In Iowa, we have a large percentage of our homes, as much as 10% of our homes in some regions, over 20 picocuries per liter. So if you keep an eye on that 20 picocuries per liter exposure for 25 years, it's represented in these next plots here. So on the x-axis, we have increasing radon exposure. Indicate overlaps with what you may find in the home setting, 20 picocuries per liter or so. But what you can see is each time the radon exposure increases for all the studies, the health risk or the adverse health effects increase as well. And if you look at the Radium Hill study, the Radium Hill study, miner study, had radon concentrations that overlapped greatly with what we find in the homes. So based on these minor studies, the EPA, or the National Academy of Science, in 1999 developed convened a group to examine the risk, and the risk is based purely on the minor studies. And what they found, they had an estimate that about 18,600 lung cancer deaths each year are due to residential radon exposure. And like I said, this is based primarily on miners and didn't incorporate any of the findings from the residential radon studies. The EPA updated this information later in 2003, but it's important to note that their demographic information was based on and if we would update this now, because we have many more homes that are not built radon resistant than we did back then, so there's a lot more people exposed. The number would probably be closer to 23,000 people or so. And you can see the EPA risk estimates. If you go to the EPA's information, you can see these kind of figures. But for smokers, estimated risk at the EPA's action level over lifetime is about 6 in 100, and for never smokers, it's about 7 in 1,000. And you compare these risks to what we see for many carcinogens that are regulated. What we find is that we're regulating most carcinogens at 1 in 10,000 at minimal, but very often 1 in 100,000. So if we really wanted to reduce the risk posed by radon, we'd have to get far below the EPA's action level, which is not a health-based guideline. That's important to note. We'd have to get down probably somewhere to below 0.04 or so picocuries per liter if we really wanted to be equivalent to what you find how we regulate other carcinogens. So since outdoor air is 0.4, we'd have to reduce outdoor air, which obviously isn't feasible, but it just shows you the magnitude of the risk posed by radon. One of the things that you look at very often, what we do is we compare the 21,000 radon-induced lung cancers to the overall number of lung cancers in the United States, which is about 160. Everything kind of pales in comparison to 160 lung cancer deaths, 160,000 lung cancer deaths overall. But that's not the comparison. Really, the comparison is how many of these cancer deaths could be avoided by reducing highly significant and something that needs to be addressed. Now, after the cold studies, or after the minor-based studies, there was a lot of concern that maybe you can't extrapolate information from the minor-based studies. Maybe you need to do studies in the home. That would give you a more valid representation of what people are actually being exposed to. Because the minor studies were just based on men. They were breathing at a rapid rate, doing more oral breathing. Particle sizes were different. So there was a big push around the world to performed studies of people exposed to radon in their home. So this is a listing of the studies that were performed in Europe and the studies that were performed in North America. And what these studies really did, like the study we performed in Iowa, is you identify lung cancer cases, you measure the radon in their home, and then you pick controls, so these would be people without lung cancer, and you compare those radon concentrations with adjustments for smoking and other sex and age, and you make these adjustments and you come up with a risk estimate. So if you look, what was done after that was there was an effort after the individual studies were performed, there was an effort to pool these studies. And you may have heard of meta-analysis. What meta-analysis is kind of it's a summary, it's a way to get a summary estimate from a lot of different studies examining the same exposure response type outcome. But what that is a summary estimate. What a pooled analysis is you take the individual level data. So it's not results offer a bigger sample size. The downside to the pooled analysis was you have to use large data. So for example, in the Iowa study, we had information where people spend time. So we took the radon concentration where they spend time in the home to come up with an exposure. But with the pooled analysis, we had to fall back to what all the studies had, which was radon concentration. So there were 7 studies done in North America, 13 in Europe, and 2 in China. And what the studies found was at 3 picocuries per liter, the pooled studies in North America found about a 10 to 18% increased risk. And the studies in Europe found about a 16% increased risk. And one of the things we're working on right now is we're working on, for the North American study, some updates to look at some of the uncertainty associated with the measurement. So that 10 to 18% will probably be adjusted over the next year or so as we do more detailed studies looking at the effect of uncertainty in the measurements. But one of the things that you look for when you're looking for causality in a study, you should look at consistency among studies. So here's the result of the North American pooled studies. And as you can see, 1 is no increased risk. 2 would be 100% increased risk on the y-axis. So you can see it increasing risk with increasing radon concentration for the pooled studies. And then here's the Chinese pooled study risk estimates. And here's the findings from the minor studies. So you can see there's a lot of overlap between all the different studies. So there's consistency between the different studies. Based on the consistency of the pooled analysis and the observation that as better information was used for exposure assessment, as you go back further in someone's life and you collect more information about their exposure, as you get better exposure information, the risk estimates actually go up versus what's presented. The WHO started the International Radon Project, about 8 years ago or so, and because of the pooled studies, they thought more action needed to be done globally about radon. So they convened a group, and you can go to the WHO, if you just search radon in WHO, you can get a good the workbook's available, and it provides really good information on radon measurement, radon health effects, you pretty much name it, and then how to really develop a radon program globally. But what's very nice about this handbook is some of the same recommendations that can be used for global outreach or to help member countries develop a program used locally as well. So going through the health effects and exposure, where you get exposure, the health effects pretty quickly. And before I move on, my email's available. And if you're doing any kind of activity in your area, please feel free to at the state level, at the national level, in different environments that you work in, say in the office where you see patients or at the health department. we really need the input. As you can see, Radon Education, there's a lot of different groups that really move toward educating the public. And medical healthcare practitioners and healthcare providers and folks at health departments, they're imperative, they're key. Very often, these are the people that are the only scientists, members of the public, really have any association with or really interact with over the month or year. So they really take what you say to heart, and you're a trusted source. So your help is really needed. So for physicians, what we're asking them to do is, just add a question on the questionnaires when they see you in the office. Have you tested your home for radon? It doesn't cost anything. End up saving their lives. There's other things that we're trying to work with. We're trying to get information out there to physicians. So we developed this paper, and we're working on some chapters to update the information for physicians so that there's reliable sources out there for environmental and occupational lung carcinogens overall for physicians. So, we ask that you read this information, share it with your colleagues, that there's good information out there that can be used for educational purposes. The other thing that's really been critical is working with groups like CANSAR, or cancer survivors. I mean, this is a wonderful group. It puts a face on radon-related lung cancer, because radon causes its effects, at least a 5-year latency period it takes before you see it. So you can't see the exposure and the result. It's not like you get exposed to radon, you walk out in front of your house and get hit. You can't see the cause and effect with these chronic diseases like cancer. But these are people that can share their stories. Never smokers, lived in a home with high radon, that put a face on it. So working with these groups are really helpful to getting the word out. And some of the biggest advances we've had in the States are led by individual members of CANSAR. So they can have you tested your home? Sharing her experiences. I think she's online with us today. So we thank her for doing that work and all the work that she's done over the many years that she's been involved. There's other groups out there too that are wonderful to work with, that have lots of energy, like Citizens for Radioactive Radon Reduction. So, learn about these different organizations and how they may be able to partner with you in your activities. Probably the group that was the most helpful to me personally as someone that's trying to get the word out has been the Iowa Cancer Consortium. They've been a tremendous resource. And one thing about when you get together with the Iowa Cancer Consortium or other health-related groups or interest groups within the state is they have their own set of partners. So when you start partnering with them, it really opens up channels to channels that they have that will help get the word out in the state that you're in. So you can see some of the partners of the Iowa Cancer Consortium. I mean, once we start working with them, that opened the doors to all these other partners to help form coalition, team building, to address the common cause of radon reduction. And this is just one outcome of working with the Cancer Consortium and the other American Lung and others within the state is their connections to, say, Blue Cross, or their connections to physicians or other healthcare providers that weren't obviously available to me. So this is something that was published statewide. Talked about a lot of studies, and Iowa Cancer Coalition were wonderful in supporting or funding the presentation that we have. It's a video. It's two videos. It's a 12-minute video and a longer video, and it really focuses on cancer within the state, but it's not really Iowa specific. It can be used by healthcare providers all over the United States. And on this site, you can see there's little pamphlets or not brochures, but posters that you can put in offices where you work. They can be printed out and put there. But also, I really urge you to watch the longer, or if you don't have the time, the shorter video. It's being narrated by Chuck Lynch, which is the medical director of the Iowa Cancer cancer registry here in Iowa, who's well known and respected nationally. So, he provides a very nice summary of radon health effects. But more importantly, at the end, if you need references, all the links to all the papers I've talked about and others are at the Breathing Easier info site. So I really urge you to go there, look at the video, and then really look at some of the studies and the evidence that I presented in the short time that I had today. So in summary, for my part, radon is a very global health concern, not just the United States, not just in your community, but it all starts locally. The word out. Like I said, I urge you to go to Breathing Easier, and then additional information on radon testing and mitigation is available at the EPA website. So I thank you for tuning in today, and look forward to working with each of you in the future.
Can people hear me?
Loud and clear, Dr. Levy.
Okay. Dr. Field has provided a great introduction to radon and the health effects and things like that. And what I'm going to discuss is a little project that we did with the Akron Mercy Healthcare Clinic up in northwest Iowa. Akron is a town of about 1,500 individuals, and we worked with their lead physician, Cynthia Wolf, in trying to get the word out in Akron about the dangers of radon. So do I move the slides?
Okay. Yes.
Okay. So Dr. Wolf was the lead physician, and we collaborated to write a small grant proposal to the Iowa Cancer Consortium and had it funded. And the idea was pretty simple. Dr. Wolf became very interested in radon after hearing a presentation at the Iowa Cancer Summit about it. She went home and tested her house, and her level was 39. And she had several people in her office test their homes, and they tested their clinic, and everybody came back with a high reading. So she realized that it was definitely a problem in the Akron area. So she approached me about trying to get some money to get the word out. So we wrote a proposal, and basically a large portion of the money provided for purchasing radon kits that could be handed out in the office. A kit from AirCheck. I don't have any disclosures. That's just the company that we happen to buy our kits from. As Dr. Field mentioned, there's short and long-term kits. This is a short-term kit that you leave in your lower level for no more than 3 days. And the company did give us a little break on, a small discount on the kits. I think they were $5 a kit. So basically the way the study was set up is the medical office staff handed out a kit with a unique identifying number. So they knew who got the kit, but we did not here at the university. And then Dr. Wolf and her staff had numerous forums in their area, just getting the word out about radon and the importance of testing in the homes. And we asked individuals to fill out a one-page questionnaire that we developed just regarding characteristics of their home. Did they have cigarette smokers in the home? How many people live there, etc. So here's some of the questions. Figure out how well each person's home was insulated, but since that was a factor in other studies, homes are built kind of better now than they used to be, and that's contributing to higher radon levels. So we went through the Institutional Review Board, the IRB, and got approval. All data was double entered and verified. And then the information from a person's questionnaire was linked with their radon result. And then if a kit was dispensed but wasn't returned, the Akron staff contacted the individual to try to get it to be returned. We weren't trying to force them to do it, but we gave them a kit. If they didn't get it back, the staff kind of got on them to return the kit. They weren't obligated to, but that was part of the idea of the whole project, was to get people to test their homes. And we just use standard descriptive statistics to analyze the data. So basically, this is a summary of what happened. We had 746 individuals that were invited to participate. We had 408 actually return their kit, and we had 378 valid test results. And I've had the question, well, why weren't all the test results valid? And what happens is if people don't fill out the clock correctly on this particular kit, the company can't tell the number of hours the kit was sitting out. So that was the problem in some cases. So overall, these subjects were about 55 and a half years. 43% had an income below $50,000, and the mean age of the homes was 54.7 years, which, I was a little surprised. So these people are living in older homes in general, and you can see the types of heating they had. Most homes were gas heating, and 3/4 of the group considered their home to be well insulated. And I think, one of the limitations is that we didn't have a way to really figure out if they were accurate or not about this, but this is what they self-reported. Dr. Wolf and her staff had over 14 educational presentations. A total of over 400 individuals attended. And the mean radon results for those 351 where we could match everything up was 10.2, which is well above that EPA action level of 4 that Dr. Field mentioned, and also well above, a level of 2 to 3 or lower that we might really want to see the homes at. And there were 8 radon values above 30. And for those 8, the mean was 45.5. So like in any kind of study, there's always some extremes. And so some of these individuals were living with incredibly high radon levels. Overall, 82% of the homes had results of 4 picocuries per liter or higher. So 4 out of 5 people that tested their home, it was above that 4, which is considered the action level. And like said, they had tested previously, and their radon levels were around 14.2 for those who could remember what their results were. And so this was a little surprising. So they had tested, but maybe some of them hadn't gone ahead with mitigation. We found no differences in radon level by the type of home heating or their income level. So whether you're, at a higher SES or a lower, it didn't seem to matter. And the only factor that was statistically significant was that well-insulated homes had a significantly higher radon level than those that were considered less well-insulated. And again, this is a self-reported variable. So consistent with other studies in Iowa, over 80% of the homes up in this northwest Iowa than homes that were not. One thing that we were disappointed by was that we had only about 50% return rate on the kits. And we felt that if we were to repeat this, or if others were to repeat this around the country, maybe having a nominal charge for the kit might help, maybe you could get a small grant to do it, but then charge people $2 or something to do it, so maybe they have a little more incentive to return the kit. People generally could fill out the form it's not very hard, but actually Cynthia Wolf created a video on how to fill out the form that goes in with the kit to this company in North Carolina. And so she did lifting. And then another thing that this medical office did was once they found so many people with high levels, they worked with their local banks to provide individuals with low interest rate loans to have radon mitigation, and they also got a list of certified mitigators to help people get their home cleared out of radon. And one thing she noticed was that they had it provided some new sort of work for the community because so many homes needed it that people pursued getting certified to be a radon mitigator that might not otherwise have done that. So that was interesting. I think she was incredibly successful with this. The staff was very enthusiastic. They have a system in their office where they can run a video of patient education, and so they would show that video that Dr. Field talked about, the 12-minute version. So when people came in and they were waiting to be seen, that was just playing in their exam room. A limitation of any kind of study like this where you're mailing a questionnaire to people or handing it to them is that it's all self-reported. We didn't call individuals to verify answers. So in conclusion, over 80% of these homes had elevated radon levels, which actually I found kind of surprising. Maybe Dr. Field wouldn't think so, but we are in that zone 1, that red zone. All of Iowa is zone 1. Not have returned the kit because they were worried that they would be high and then be sort of needing to mitigate, which can cost a fair amount of money. And we talked a little bit earlier about the deaths due to radon, where in the state of Iowa it's estimated to be about 400 deaths each year. But nationally it's cause number 8 of cancer death overall, or thought to be. So, and then we feel like we had really good collaboration between university doing things that we're good at and the office staff that was located 8 hours away, basically doing a really good job at what they're good at. Was a really nice collaboration. So I would just sort of leave you with the thought that everyone should have their home tested, because you don't know what your level is unless you test. And if it's high, get your home mitigated. It's fairly straightforward for most homes to be mitigated. And this slide, I've put together a list of websites where there are various things, pamphlets, and I think my final slide, these are my acknowledgments. So we were fortunate to be funded by the Iowa Cancer Consortium, for which we're very grateful. I believe their money came kind of dispersed through the Department of Public Health. And then I had a grant from the National Cancer Institute that also helped some with this. And it was instrumental to have the Akron Mercy Medical Clinic helping us. And so this is shows Dr. Wolf. She's there in the white coat. I don't know if my arrow works on your slides, but okay, yeah, in the white coat, yeah, there she is. She's been in practice. She grew up in California and moved to Iowa to pay off a student loan and has been in practice over 20 years. And anyway, that's her staff. And I would have to say that everyone in the office was fully behind the project. And that was what helped it work as well as it did. So I thank you very much for your attention. I think we have time for some questions.
All right, thank you very much, Dr. Field and Dr. Levy. So as Dr. Levy just mentioned, now is the time for questions. So if you have questions that you would like to type into the chat tool, we'll give you a couple minutes to do that. And if you are on the phone, you are also welcome to ask questions. If you have muted yourself using the *# tool, we just ask that you push *mute again to unmute yourself and that you introduce yourself before asking your question. So Dr. Field, there was a question that's in the chat tool that was entered during your presentation that says, what is the referent population for the RR equals 1? Dr. Field? Having a little trouble hearing you, Dr. Field. All right, so the next question while we try and get Dr. Field back online here is, would the ICC have other...
Anybody hear me? This is Barcey. Okay, I'm wondering if Rachel or somebody from the ICC could address that.
Yes,
I'm back on. Sorry, somehow I got disconnected. It's Bill Field.
Okay. Hi, Dr. Field. So there's a question about grant opportunities from the ICC. So every spring, the ICC releases a grant opportunity through our IFP process. So that will be coming out in March. And we would welcome projects that were similar to Dr. Wolf's project. So those projects do have to be implemented in Iowa. And if you are an ICC member, you'll be receiving information about that. And if you are not an ICC member, there will be information on our website in March when it is released. So Dr. Field, there was a question for you that was entered during your presentation. That was, what was the referent population for the RR equals 1?
Yeah, so I think it's referring to the maybe some of the slides I presented for the cohort studies, minor studies. If not, please let me know by email and I'll answer that. But generally for the cohort studies, it's a appropriate reference population that in age and sex to the population of workers. And very often the reference population can be an internal population. So you compare the workers that had higher exposures to workers that had lower exposure. So there's a couple ways to get a reference population. But if there's questions regarding specifics, I'm ready to answer those if the individual wants to email me.
Thank you. Are there other questions?
Can you hear me?
Yeah.
Hello? Oh, this is Steve from Wyoming. I got in a little bit late. This presentation will be on the web so that I can access it later?
Yes, this presentation will be recorded and we will email the link to all participants.
Thank you.
Yeah, and well, probably the easiest way is if there's a state hygienic lab or a laboratory. There are some commercial kits out there, but they're a little bit harder to find than the radon testing for air. but you can also Google water radon testing, and there's some laboratories, but some of the same folks that sell or market the air detectors will also have a radon kit. And it's a little bit tricky, as you can imagine, since radon escapes so quickly from water. There's sort of an art to collecting it, so it doesn't escape while you're collecting it. So it should have good instructions on how to do that. But what I've seen is these kits are generally about $25 or $30, and if someone would like to do some water testing and they can't find a laboratory, feel free to email me and I can provide a list of some folks that do that. But then again, I think that really since the majority of the health effects come from inhalation after the radon in the water is off gas, the first step is really to do the testing of your home air. So if that's below 4, but even hopefully below 2, then you're looking pretty good. But as I said, there's about this 10,000 to 1 transfer ratio. So you need about 10,000 in water to get about 1 in indoor air. And for example, in Iowa, our highest wells are around 6,000. So that's contributing very little to our indoor air. But there's some states where the waterborne radon concentration can be the primary source of the radon in a home. But again, if someone needs a link or contact for water testing, please email me.
This is Steve in Wyoming. Can I ask a question then?
Absolutely.
Dr. Thiel, as a follow-up to that water question, I have a question. I do a lot of presentations for real estate agents, and they ask that particular question about, from wells and whatnot. So would a proper answer as comparison be that if the stomach can take very hot, spicy food, even these ghost peppers and whatnot, and people eat all kinds of stuff and they get heartburn, and that radon and water really isn't going to do a whole lot because the stomach is built for digesting food and sort of an acid cauldron.
Yeah,
Is that?
Well, that's part of it. Plus, you have a lot more sloughing off of the cells in the stomach and the intestines than you do in the lungs. So there's a lot higher turnover rate. But there's an excellent lung cancer or radon-induced cancers from drinking water, and they do predict a small number of stomach cancers related to drinking the water. But the stomach, and you think about how far an alpha particle can go, and there's a lot. Generally, it doesn't get the alpha particle or the radionuclide, the polonium, or whatever is in the stomach that could be generating the alpha particle isn't usually even attached to the surface of the stomach. It's usually in further, or there'd be some attenuation before the alpha particle can even hit the tissue. So there's a lot of reasons why the doses are much lower.
And the most we've ever had in Wyoming is a little bit of 8,000 from the U.S. Geological Survey. So 8,000 is 0.8 when it comes to the air.
0.8, right.
And so in Wyoming, we really don't have a problem, and people really shouldn't be concerned about radon in the water, just radon in the air.
Right. And that's why I say, even in states where it's high, I think the first thing to do is to really test the air. The EPA years ago came up with a maximum contaminant level of 300 picocuries per liter. But that was based on the 1 in 10,000, 1 in 100,000 chance of causing cancer. And then they realized that 0.3 is contributing less radon than if you open your window. But they're trying to get it down to the risk estimate that's really that's a health-based risk estimate. And then they came up with a plan. Well, why don't we come up with an alternative? If the utility will make efforts to reduce radon in homes for their distribution area, then why don't we make it 4,000? Because that will give you 0.4, and that's what outdoor radon concentrations are. So they came up with that, but that's never been promulgated as well.
Great. Thank you very much.
Okay, the next question is, are there any suggestions for grants for radon education outside of Iowa?
This is Bill. What I would suggest is contacting your state Department of Public Health. At least I hope for one more year there'll be some state indoor radon grant money. For 2016, it's canceled out again. So there were a few $1 million set aside for the states for these kind of activities, but I would check with them because it's been canceled out for a few years in a row, and each year we're able to work and get it put back in the budget. So I would start there with the radon groups within the state at the health department. Then I would also check with cancer consortiums. We have them in many of the states now, and if you're interested, if there's one in your state, I can provide some information if you can't find it by searching or talking to physicians at the university. But that's another good source.
Right, do we have any other questions?
And a couple of years ago, the National Cancer Institute had something called R25 cancer education grants. I don't know if they're still being offered, but that would be another place to look.
Right, EPA also has some grants out that could address radon if you can link disparities within the grant proposal. And radon is one of those things that there are certainly what happens if someone lower socioeconomic does do testing, and then it's going to be this charge to help to fix it, which can be $1,000, $1,100. So, that's the issue with disparities. So that's why we're really trying to work with legislators in the states to try to get radon-resistant new construction. Because that's really the first step with stopping the loss. Right now we have more people exposed to radon than we ever have. And if we can just get radon-resistant new construction, we'll stop that always coming from behind, trying to get homes mitigated faster than homes are being built without radon-resistant construction. So there are disparity-type grants out there that you can tie radon into, so that may be an avenue as well.
Right, any other questions from participants? In the chat tool, I did include Dr. Field's email address if anyone would like to contact him with any further questions. And then the question about comprehensive cancer control programs, I also inserted a link for how to contact the Comp Cancer program in your state.
I wanted to mention also that the mitigation, one of the few benefits that are out there for assistance is when you put a system in, if you have a federally funded equivalent healthcare financing or healthcare spending account, it is a covered expense like lead paint removal under your healthcare spending account. So if you happen to have one of those, the cost of mitigation can be used, can be paid by that account.
Well, I thank everyone for joining us, and we'll be emailing out the link to this recorded presentation for everyone if you guys have colleagues that you would like to share it with. So again, I just want to thank Dr. Levy and Dr. Field for presenting all of this great information today, and I thank all of the participants for joining, and I hope all of you guys have a great afternoon.